So another complications of MIs is interventricular septum rupture. Here again, 3 to 5 days. So this would be your board question. Patient had a MI. They went home from the hospital. 3 to 5 days later after that, they had what? And basically they probably had a lesion in their LAD, and they come in with chest pain. Here again, whole systolic murmur, being in systolic and diastolic, and they come in with shock. So echo will show is a right to left ventricle shunt. So it's going between the ventricles. So your septum is between the ventricles, and you're having basically a rupture between there, and you have a hole and it's going between that. So you have increased oxygen level in the right atrium to the right ventricle. Now let's look at another complication. And they like to put these on boards just to get you focused on what are these complications that can occur after an MI. We have a free wall rupture. This can happen later. This is 5 days to 2 weeks. Now, all these are going down because we're getting better, and that's why when your hospital says, hey, we have our door to balloon time, this is why it's so important. The faster we can get into the cath lab to open up those lesions, the faster we open up those lesions, the less tissue death we have and less complications we have. So that's why it's so important. That's why these hospitals are graded on it. That's why these hospitals publicize how fast their data is. That's why they have these cath labs available for them to go as fast as possible so we can open up these lesions. So these events are going down, and you're less likely to see these, but they still can happen. Here again, it's a lesion in the LAD. The patient comes in, very similar to all these, is that you're gonna have chest pain, shock, and you can have distant heart sounds. So if you see where it says distant heart sounds in your clinical vignette, this is where you think of free wall rupture. The echo is gonna show what? A pericardial effusion with tamponade, because you're basically having blood getting into this. These are pretty dramatic, okay? So that's gonna be your decreased heart sounds. Just think about it. You have fluid stopping from the noise coming from your heart from getting to your stethoscope. What's the treatment? Is surgery, and it's emergent surgery. All right, now let's talk about more complications following a STEMI. Complications can occur early in the management phase of a STEMI. Arrhythmias, so this tissue has been damaged. So remember, we have nerves that run in our heart that carry rhythms, right? And these are living tissue, and if they don't perfuse, they can have damage. And 70% of these patients experience during the peri-infarct time period. So when somebody's coming in for a heart attack, you're gonna see where they have a cardiac arrhythmia. Can be also noted is heart failure. You can have heart failure. Remember, the tissue has been damaged from the heart, so you can have heart failure, meaning that the heart, the tissue in the heart, the myocardium isn't squeezing well. So what's gonna happen? It's not gonna squeeze well, so you're gonna have what? You're gonna have backup of fluids. So you're not moving your blood as well as you should. You're gonna have vascular collapse, and then there can be complications from the PCI excess, as we talked about. You can have hematomas at the site, or you have retroperitoneal bleeds. And vascular collapse, fancy word for saying shock, okay? We're not perfusing to the body. That's why we go through everything we do in the hospital of giving pressors, doing different agents so that we can get blood flow to the body, to the organs of the body. There's continued discussion of complications following a STEMI. Right ventricle infarct. Now this is a board question they love, okay? Occurs in about 1/3 of the patients with an inferior wall MI. Clinical features of this. Inferior wall MI, you're gonna have decreased blood pressure, and this is an increased JVP and a positive Kussmaul sign. What's Kussmaul sign? Is a paradoxical rise in, right here, in your JVP pressure on inspiration, or failure for it to fall. So we'll talk more about this. Is a Kussmaul sign. And Kussmaul did a lot of things. He was in the 1900s, and you're gonna see a lot of things that this gentleman did as far as Kussmaul sign, Kussmaul's breathing. Remember Kussmaul's breathing in DKA is just where someone has a deep, rapid breath. What are they trying to do? Is they're trying to blow off what? They're trying to get CO2 out. So because they're in an acidosis, in DKA, diabetic ketoacidosis. So this is the key when we're going back and discussing this, is clear lung fields, okay? So these people are in shock, okay, but they have clear lung fields. So it's a different presentation. So clear lung fields. So they have an inferior wall MI. They have increased blood pressure, decreased blood pressure, increased JVP, and they have a positive Kuhl's-Moll sign in clear lung fields. Now there's typo, as you can see here, it's JVP, not GVV. So what's the treatment? So this is going to be in your board question. You're going to give them fluids first, okay? Give them fluids and then inotropic support. You can use dobutamine or dopamine depending on what your facility uses, or Levophed, and we'll discuss the pressors and what's the order of pressors and what pressors you can use. We want to avoid diuretics. So this is where it's being important, because you feel this patient's in heart failure. And this is what the boards is trying to teach you is this patient is given a presentation of heart failure. They're going to have decreased blood pressure. They're going to have an elevated JVP. And then they're breathing up, and you're going to watch this, you're going to have a high JVP right here, this extraordinary, so higher than what it should be, and it's not coming down. When it doesn't come down like that, you're going to look at this patient, you're going to feel they're in heart failure. But they're going to have clear lung fields. That's the key. So you want to avoid diuretics and nitrates, because you could actually hurt this patient to that. So the first thing you do is you're going to protect the MAP, and we'll talk about this, is you always want to make sure you have a MAP greater than 65. The reason why is we want to perfuse our brain, we want to perfuse our kidney, we want to perfuse our end organs. So we want to protect our MAP, and we can do it through, if we eat fluids, volume loading, and or dobutamine, dopamine, Levophed, norepinephrine. So that volume loading is so important, okay? So this would be is, you're going to get this board question, and you're going to look at it, and this patient appears to be in heart failure, but they're really not in heart failure. They have had an inferior wall MI, and we need to, at this point, support their blood pressure. All their treatments MI include thrombolytic therapy and PCI as indicated. So we talked about this. What are some common heart rhythms following a STEMI? We can have bradycardia with hypotension. This is common with an inferior wall MI. Sinus tachycardia, commonly seen. This is an anterior wall MI, it can be seen. It can be a persistent sinus tachycardia occurring days, several days following a STEMI, and can be early manifestation of heart failure. Usually it's a poor prognosis. Atrial fibrillation can be transient and occurs in a patient associated with pericarditis. That's inflammation of the cardiac sac surrounding the heart after a myocardial infarction. All right, let's talk about this. Let's look at this EKG real quick. All right, so once you get in the habit of looking at these EKGs, and I want you to start looking, it's harder to see on the screen, but we're looking at these large blocks right here, and we're looking at the distance of these large blocks. So you need to be able to look, and we're looking between what? The QRSs right here. Here's our QRSs, and we're looking at how many blocks between our QRSs. When there is greater than 5 blocks, and we can definitely see here is there's greater than 5 blocks between it. So sometimes we don't get the luxury of sitting and reading EKGs and fully reading them right away. We have to look at them quickly, or we have to look at the cardiac monitor. If we know there are greater than 5 blocks, we have a bradycardia. On this, even on our rhythm stress, we can see that, indicating it's a heart rate less than 60 beats per minute. That's bradycardia. And sometimes on boards, they'll give you strips like this where they're very hard to see, and you just basically can see these large blocks. And so you're looking between the RRs, okay? All right. Sinus bradycardia, we'll talk about this. Heart rate less than 60 is due to the heart sinus node or conducting pathways leading to slower electrical impulse generations or transmission. Now, there are certain people that are normally going to have sinus blocks, or they're going to have bradycardia. Now, you can have somebody, extreme athletes. Lance Armstrong was an example, is when he was riding in the Tour de France. Now, his heart rate was in the 20s when he's going up these hills, where most of us heart rates would be in the 200s, or we would be dead riding up these hills. And his heart rate would be in the 40s, 60s, because his heart was trained to be more efficient. Now, a lot of the patients we see are not trained like Lance Armstrong, so they have other reasons for bradycardia. So what are we being looking for? We're going to talk about the diagnosis. Simple as the EKG, the Holter monitor, blood test. What do we want to check if someone has bradycardia? We want to look at their thyroid function, look at their electrolytes. There's something we could do as an EKG as an exercise stress test. Risk factors can be aging, coronary artery disease, heart failure, hypertension, diabetes, all these things that help us not perfuse as well as we should. Now, this could be it, is patients may be getting beta blockers and calcium channel blockers. Now, say for example, somebody's been getting beta blockers or calcium channel blockers and they suddenly have a flu, okay? They have a flu all of a sudden, and they have nausea, vomiting, and diarrhea. So what happens? Why is the mechanism, why would they have bradycardia now? Huh?
Vasovagal?
They could have a vasovagal, or how about is that the medications can be broken down by our kidneys. So if we have, just if you agree, if somebody has a flu, their kidney, they're not going to be taking in, they're not going to be hydrating, they're having nausea and vomiting, so they have volume depletion. So when they have that volume depletion like that, that volume depletion is going to cause us to have acute kidney injury. So when you have an acute kidney injury, you have to agree is that you're not going to break down these products as well. So it's a simple thing you'll see in the hospital quite often, is someone who takes these medications for years, even decades, who suddenly has a change in their kidney function. Could be they had a cold or flu with nausea, vomiting, diarrhea. Maybe they had C. difficile, where they have huge volume depletion and their kidneys don't work as well. When they don't work as well, they don't break down those products. So these products are retaining. It's almost like you have a bucket where you're putting these in a bucket, but you don't have a drain out of that bucket. So what's the management of this? Is that you can use atropine can be used. You can also use epinephrine, or you can infuse you can use Levophed, dopamine, dobutamine. These are other medications, so you're trying to get inotropes. You're trying to get the heart rate up, okay? Clinical features, what does your patient have? Weakness, fatigue, lightheadedness, syncope or neurosyncope. You're not perfusing the brain, as the heart is not being able to squeeze. So remember, cardiac output is, what is the cardiac output? Is going to be what your stroke volume is times your heart rate. Stroke volume times your heart rate. So if your heart rate is slower, you're not going to be able to get your cardiac output decreases. With some other things, shortness of breath. Remember, we talked about signs of poor perfusion. This one I'm trying to see is, I want you to start looking at your patients and looking at, are they perfusing? Are they getting blood flow to their vital organs? Chest discomfort, they're not getting enough juice to their heart, to their coronary arteries. Confusion, okay? The supercomputer up here, just like your laptop, if it doesn't get good energy supply and the battery's getting weak or the battery's corrupted, it doesn't work as well. The same thing goes for your brain. Now, and we talked about this, some patients, especially athletes, like Lance Armstrong was able to get a resting heart rate of 20, and then when he's going up in the Swiss Alps, he's in the 60s. Okay, we probably don't see that too often in the hospitals, but this could be a patient. You could have people that are elite athletes that will have that. So there can be intrinsic and extrinsic cause. The intrinsic cause is that, so right here is the sinus node is coming down. As we look at this right here, is the sinus node coming down. You can have sinus node dysfunction. You can have things called sick sinus syndrome, okay, and you can have an AV block, and we'll talk about this. You can have an MI, and just think about just the nerve conduction tissue is a living organism, and that tissue can have where it's disrupted, and that tissue can have death, and it doesn't conduct as well as it did before this patient had an MI, just like the heart tissue itself has problems. Or you have cardiomyopathy. What's the extrinsic cause? We talked about beta blockers, calcium channel blockers, and even people, because some of them are going, well, I've been taking these medications for years, I've never had that. Maybe they had a change in their kidney function. Maybe these medications are also broken down by their liver and they're having liver dysfunction. So these medications are being built up. Hypothyroidism, electrolyte imbalances is a big one. That's why you want to measure your electrolytes right away and see if there's something you can fix right away. Hypokalemia can cause this. And increase intracranial pressure. When we get to the neuro section on this. Other is ischemic heart disease. Remember, these nerves are living organisms that come through. Also aging. As we get older, these nerves that conduct these pathways don't work as well. Sleep apnea can do it too, and myocarditis. Talk more about sinus bradycardia. The rate is going to be from 1 to 59. You're going to see P waves with a sinus rhythm. So P wave before carries through. Your QRS is going to be normal. And our conductions, you're going to have normal PR conduction. So meaning you're going to have a P before an R, a P before an R. And a slightly prolonged or lower rates can be too. Can have a regular rhythm or irregular. The rhythm is also seen as a normal variation in athletes, as we talked about. or in sleep. And you can, patients who are sleeping at night, some of them will get bradycardic. You may even get bradycardic. Maybe because you have sleep apnea, maybe you don't. In response to a vagal maneuver, okay? Different vagal maneuver can rub our carotid sinus, and that can cause a vagal maneuver. If the bradycardia becomes slower than the SA node, pacemaker node, it's called a junctional rhythm may occur. Now, a junctional rhythm is a cardiac rhythm originating from the AV node, okay? Now, we talked about before is the SA node. It may originate from the AV node, which is lower down rather than the sinus node, so it would be slower. Treatment includes treating the underlying cause. So if there's a beta blocker, either overdose or if their kidney function is bad, is working on the kidney function, holding the beta blockers. If it's hypothyroidism, treating the hypothyroidism. You would do immediately, if you need to, if they're not perfusing, give atropine or epinephrine to cause perfusion. And artificial pacing if the patient is hemodynamically compromised, meaning you place pacer pads on the patient and you increase the heart rate. Because remember, cardiac output is what? Ejection fraction times heart rate, right? How much you're squeezing out of the heart, how much blood is coming out, times the heart rate itself. More discussion on heart rhythms following a STEMI. Now, complete heart block, that's where you associate with an anterior or inferior wall MI. And that's where the top and bottom of the heart, the atrium and the ventricle, they don't talk to each other. Like they're divorced, okay? They're divorced parents, and the top and the bottom don't talk to each other. So that you don't get that rhythm coming through. So they beat independently. They're divorced. They don't care. They're doing their own thing. They're going separate ways. The top part's doing their thing, the bottom part's doing their thing. And guess what happens? The kids, the heart doesn't do well, the body doesn't do well, because the parents aren't talking to each other, okay? An inferior MI can cause a complete block. There's usually transit, but may require temporary venous pacing. An anterior can cause a complete heart block, usually indicates a large infarct, and a poor prognosis usually requires permanent pacing. So meaning that once you have this complete divorce between the top and the bottom, is you have to do something, an intervention, so that they communicate. Or not even so much communicate, is you have to artificially pace the top and the bottom so they can work together. You're trying to get these parents to work together. Now this is the big one, the VTAC. Now this is the scary one, and this is a sign where the heart is just kind of doing this, but it's going fast, but it's not getting anything, it's not giving any meaningful perfusion to the brain, to the organs. It is beating fast, but nothing meaningful. So you see a rhythm on there, but nothing meaningful. Usually occurs within the first 24 hours following an MI, and is usually self-limiting. But if it occurs later in a hospital course, it can indicate a larger MI, and it has a high long-term mortality risk. First degree AV block. So we're going to be going and discussing these different blocks. These are just going to see. So when you get boards, or even when you're working up on the wards or working in the ICU, you're going to get these strips like this. So you have to get used to looking at strips. We don't always get the advantage of having that 12 lead. Now, as technology gets better, who knows, we'll have a handheld device that you just pop on their heart and you get a 12 lead right away. But the reality is a lot of times you're going to get these rhythm strips. So you have to get used to them. The boards likes testing these because it's a little bit harder and it's a little bit more challenging. So an AV block is a block, it's an atrial ventricle. It's a block between the atrial and ventricle that is defined as a prolonged PR interval greater than 200 milliseconds on an EKG with preserved AV. So it's atrial ventricle 1-to-1, so it goes through the atrium, goes to the ventricle. It's preserved, meaning it goes through. It's just a delay. All right, it's like your slow cousin, okay? Your cousin, the hard part beats, and then they don't really get everything done. So it's just like your slow cousin, okay? This is what you got is, see this right here? This is your slow cousin. They're supposed to be coming to pick you up, and this is where they are. They're late, okay? They're late all the time. Your slow cousin coming to pick you up. And always slow going through. It happens, but it's just delayed like your cousin. Etiologies can be as increased vagal tone. It can be, and athletes can have this. Medications. And here again, is beta blockers can cause calcium channel blockers if somebody's taking digoxin. And ischemic heart disease can also, because remember, this tissue gets damaged, this conduction tissue gets damaged. And you have delayed conduction through the system. Can also be seen in neuromuscular and infiltrated disease. Maybe the patient has sarcoidosis, okay? And that sarcoid is, there's a granuloma and it's blocking the pathway between the two. we always have to think about vagal tone, and you may get this with patients. This is something we'll kind of talk about briefly. Is you have your sinuses right here at your carotid. You have these sinuses, and when somebody if somebody has a tachyarrhythmia, we can always give them a carotid massage. And where do you do that? It's at your mandible, the corner of your mandible right here. So right here, roughly right here is where we would give that sinus massage. Now, some people are very sensitive to that, and you can have a real world question, or you can have a board question. Is that someone comes in, it's usually a gentleman who's wearing a tight shirt, and they're wearing a dress shirt, and they're going to wear a fancy dress shirt with a tie, okay? And that they're putting it, maybe they've gained some weight and they didn't get new shirts, and they have to kind of fuss to kind of lock that button down, and then their neck is getting pushed on it, and they turn their head, and they're pushing that carotid sinus, and it can collapse. I had a friend who had a very sensitive carotid sinus. He turned his head and he fall down. And we'd have to take him to the hospital and turn his head and fall down. They're like, can you stop turning your head? Just keep your head straight. So this is things that can happen. These are real world things. Now, the reason why this is important, boards would want to do it, is you can avoid this huge workup if you can figure out what's going on and why this patient is doing it. So instead of going to the hospital and they're getting all these tests, these are things that we can work through. Or you can help explain it to a patient is, oh, you're out and you're going to work and you're wearing a suit and a tie, and that tie was tight and that shirt was a tight shirt, and you turned your head. That's one of the mechanisms that can happen. All right, so more discussion on the first degree AV block. Now, we talked about what they can be due to is inferior MIs, digitalis toxicity, hyperkalemia, increased vagal tone. We talked about turning your head. Rheumatic fever. We don't see that much in the US, but maybe you have a patient that immigrates that has that. Myocarditis. The rate can be variable. P wave is normal. Remember, you get in that first P wave, it's the conduction going through. The QRS is normal. It's the conduction between the two. That's where the problem is the conduction between the two. Impulse originates in the SA node, but it has prolonged conduction to the AV. So you have SA, AV. It's taking time to get there. And the interval noted on the PR is greater than 0.2 seconds. It's a regular rhythm. It's going through, it's just delayed. This is the most common conduction disturbance. It occurs in both healthy and diseased hearts. Interventions include removing the underlying cause and observing for progression to more advanced AV block. Now, do you really treat this? No. Okay. Now, do you want to avoid some medications? You may need to avoid a beta blocker. You may want to avoid a calcium channel blocker, because those are going to delay it even more. This is something where you're probably going to need to get expert assistance to kind of discuss this. Maybe this beta blocker is very important for this patient and other things that they have, and you have to discuss how are you going to manage this patient. But you want to avoid things that are going to slow down that SAAV node conduction.